Assalamualaikum and hi to all. Today I'm going to present about our data visualization project. So the dataset that we use is hospital admission trends and healthcare access in Malaysia in 2024. So moving on to the next slide. So this is all of our group members. The first one is Elaine Chelian, and then we have Rashuri, and then me myself, Muhammad Afiq bin Zakaria, and the last one we have Adrian Anthony. So let's move on to the introduction of our project. So Malaysia operates a dual-tier healthcare system. The first one is public sector. It is a government subsidized, accessible to all citizens. And the second one is private sector. It is a fee-based and often concentrated in urban area. So while this model aims to provide broad access, rural regions face challenges such as fewer hospitals, limited staff, and longer travel distance. The purpose of this project is to analyze hospital admission trends and healthcare accessibility across all 13 states and 3 federal territories in Malaysia. And second one is to identify regional disparities in healthcare infrastructure, workforce, disease burden, and also budget allocation. So why this topic matters? The first one, healthcare equity is essential for national well-being. Second, data-driven insight can guide policy decision, resource allocation, and public health planning. And the last one, the project support effort to ensure fair and equal access to quality healthcare for all Malaysians regardless of locations. So let's dive into the problem statement of our project. So urban versus rural disparities. Urban centres like Kuala Lumpur, Selangor and Johor have better access to both public and private care. Rural states such as Kelantan, Perlis and Sabah rely heavily on government hospital with limited private option. So workforce and budget allocation are skewed toward urban area, creating services gap. So the key challenges in healthcare access, the first one is uneven distribution of hospitals and medical staff across Malaysian states. Second, rural area often lack sufficient healthcare infrastructure and personnel. And the last one is long travel distance and high cost discourage timely care and undeserved regions. So why this topic matters? So Jaffa et al. In 2013 state that healthcare services are disproportionately concentrated in urban centre. Second, Abdul Hamid et al. In 2023 state that rural communities face accessibility issue due to distance and infrastructure. And the last one, Manuel et al. In 2024 state that utilization of healthcare services in Sabah is affected by transport and cost barrier.
Hi, my name is Rashid Aringa. Today I'm going to explain about the data source and tools and technology that we use. For the data source, we have three. First one will be Ministry of Health Malaysia, MOH, Health Indicators 2024, which consists of hospital count, staff number, budget allocation. The second one will be Health Facts 2024, admission, disease case and mortality statistic. The second one will be OpenDOSM, Department of Statistics Malaysia, which is state level population and economic data. The third one will be COVID Now Archive, GitHub, which has historical COVID-19 cases data by state. Next will be tools and technology that we use. First is Python, main programming language for data analysis. Pandas, which data cleaning, transformation and aggregation. Seaborn and Matplotlib is for statistic visualization, which consists of bar chart and heat maps. Plotty is to interactive charts and choropleth maps. And lastly is Streamlit, which is dashboard development for real-time data exploration. For the data preparation, first we will be doing cleaning and formatting, which is import Excel data set using Pandas Real Excel. Second is standardized text field, for example state, healthcare sector, to title case for consistency. Third is rename columns for clarity, dengue fever to number of dengue fever cases. The fourth one is handled missing values for threatening blank of 0 or excluding them from filters. Next is about long form transformation, which is converted wide format data to long format using Pandas Melt. Second is enable group bar charts, pie charts and animated maps. Third is simplify plotting across multiple disease and sector. The third one is derive matrix, calculated admission rate per 1000 people. The formula will be rate equals to admission divided by population times 1000. The third one is normalized comparison across states with different population size. Next, I will be explaining about dashboard overview. There are three. The first one will be interactive filter, state selection, view data for individual states for all Malaysia, healthcare sector, filter by urban, rural classification. Third is disease type, choose from 12 major disease, for example COVID-19, dengue, TB, hospital and staff type, toggle between government and private hospital staff. The second one I will be explaining about purpose of using Streamlit. Enables real-time interactive and dynamic filtering, make data accessible and engaging for user without coding skill, support evidence-based decision making for health planners and researchers. The third one is the type of visualization. We have 5 type, which is bar chart for admission, hospital beds, staff distribution. The second one is pie chart, it is for disease proportions. The third one is heat map, it is for disease intensity by state. The fourth one is line chart, admission rate per 1000 people. And the fifth one is animated choropleth maps disease spread across state.
Hi everyone, my name is Lenchilin and this is our data visualization project on Malaysia's healthcare system. We used national health data to build an interactive dashboard showing key patterns in hospital usage, workforce, disease cases, and health outcome across states. The first slide is all about admission and hospital availability. The government hospital handle most admission, especially in Selangor and Johor. Private admission are more common in urban, affluent states like Kuala Lumpur and Penang. Urban states also have more hospital overall, while rural area have fewer private hospital, showing the access gaps there. The second slide is about workforce and bed capacity. Government doctors dominate across most states, while private doctors are centered in urban areas. The same goes for nurses, mostly in government hospitals. Private nurses are in short supply in rural regions. Government hospital beds shows high occupancy, especially in KL and Selangor, hinting at overcrowding. Private hospitals have lower occupancy, possibly due to cost or insurance limit. Rural beds are often underused. The third slide is all about childbirth and disease cases. Sabah and Johor have more childbirths due to bigger population. Selangor and KL lead in disease cases while rural states report fewer, possibly due to underdiagnosis. Small states like Perlis and Labuan show lower count, matching their population sizes. In our dashboard, we have also shown mortality and budget statistics as well. In this fourth slide, we have shown that urban areas shows higher mortality rate, likely due to more cases and better reporting. Urban states get more government health spending per capita, while private health spending is bigger in wealthier states. Rural deaths are low but may not reflect reality due to data limitations. We have also talked about disease distribution in our fifth slide. Selangor and KL make up a big portion of national disease cases. The heat map shows disease hotspot like Selangor and Sabah, which is useful for planning intervention and targeting resources. In our sixth dashboard slide, we have talked about admission rate and animated disease map. Kelantan and Terengganu have high admission rate per 1000 people, hinting at gaps in prevention or chronic disease care. The animated choropleth shows us how diseases like COVID-19, dengue, and TB are spread geographically. It helps in identifying hotspots and support better health planning and targeted action.
Slide 14, I'm going to explain about the findings and insights. So, as expected, Selangor, Kuala Lumpur and Johor consistently show the highest number across hospital admissions, disease cases and also healthcare workforce availability. So this reflects a robust infrastructure but also indicates intense demand and pressure on the system in these urban centers. So in contrast, rural states like Perlis, Kelantan and Labuan faces major challenges, and this includes fewer hospitals, minimal private sector presence and reduce the healthcare accessibility as well. So these gaps highlight persistent urban-rural healthcare inequalities that can severely impact health becomes in underserved areas. In slide 15, I'm going to explain about the overall conclusion. So there's a clear disparity in funding, staffing and healthcare infrastructure between urban areas and rural states. So in urban areas like Selangor, Johor and Kuala Lumpur have well-developed healthcare services but also bear the highest disease burden. So meanwhile, rural states not only lack of facilities and staff but also limited access to private healthcare. So these insights stress the importance of targeted resources, allocation and policy support to bridge these gaps and ensure equitable healthcare access across Malaysia. So that's all from us. Thank you.